morning, everyone. I'm so privileged to have this opportunity to talk about some new and 6 o'clock single-use digital flexible ureteroscope. And if you don't mind, I want to introduce myself a little because my name is Youg Cho. Koreans don't have any middle name system, so you can just call me Songyong or Dr. Cho. This is a new scope, the first single-use flexible ureteroscope with 6 o'clock working channel position. It has two directional 270 degrees deflection and sensitive one-to-one lever interaction. Some people ask me if I am the chief medical officer of this company, but I'm not the chief medical officer. I am interested in some. I'm just a surgeon who is seeking for the best treatment for my patients with stones and BPH. So I want to introduce one of my cases. His 59-year-old male with a month history of left flank pain, and he didn't have any history of urinary tract infection or lower urinary tract symptoms. And regarding the vital sign, the physical examination and laboratory tests didn't show any abnormalities. No specific findings were found. Although the creatinine level is a little bit high. And when I checked the separate renal function, the left-sided kidney showed a 30% decrease of renal function with DTP renal scan. So KOB shows several stones in left-sided kidney. And the CT scan in the coronal view showing a mid-pole stone, lower-pole stone, and maybe a small stone in the renal pelvis. But actual views are showing this mid-pole anterior stone, mid-pole posterior stone, and lower-pole major callus stone. So the assessment was multiple left callus calculi with left mid-pole anterior callus stone, left mid-pole posterior callus stone, and lower major callus stone. With the Hounsfield unit 1124, it may mean a little dense stone, a very hard stones to break with. For example, shockwave lithotripsy. So I planned a retrograde intrarenal flexible ureteroscopic surgery in the left kidney. So normally I am using a mini nephroscope because my hospital is the tertiary hospital regarding the endoscopic stone surgery for Korean people. So I am performing the endoscopic combined intrarenal surgery in almost 70% of my cases for complex renal stones. So I want to save some time to change the scope from cystoscope to miniscope nephroscope. So I'm using this, and I am inserting nitronal guide, hydrophilic guide wire into the ureter first. And I'm checking, I'm inserting the guide wire, safety guide wire and the ureteral catheter of this guide wire. And I'm checking the retrograde pyelography to check if there is any anatomical abnormality like duplicated kidney. So I could see upper, middle, and lower callus in a single shot. So I am now inserting the safety guide wire with a dual lumen catheter. And I'm inserting the traditional ureteral accessories through the working channel. Actually, my preference is reusable digital flexible ureteroscope at 3 o'clock. So I'm navigating all the calluses because I want to check the stone locations, the location of the old stones inside the kidney. And I could see here the mid-pole posterior callus stones, and there are two stones. And with the 3 o'clock working channel, actually the left side of the left kidney means dependent position of the kidney. So if there are two stones in the mid-pole posterior callus, the 3 o'clock working channel laser fiber can reach the stone in the right side very easily. But for the left side stone, actually the half of the endoscopic view is covered by mucosa. But with 6 o'clock working channel, actually we can get a wider wide angle of the endoscopic view. So only the 1/3 of the mucosa is covered, and that's an endoscopic view. So regarding the wrist movement, actually, with the flexible URS at 6 or 9 o'clock working channel, you could see the more just aggravated wrist rotational movement of the wrist with the 6 o'clock working channel. But with 6 o'clock working channel, you can see the less fatigue with the less rotational movement of the surgeon's wrist. With the flexible ERS at 6 or 9 o'clock working channel, this yellow part is the endoscopic view. So we can see the other black spots with the flexible ERS at 3 or 9 o'clock working channel. But with the 6 o'clock working channel, we can see the wider field of view with less area of dead spots, blind spots. And actually, this is when I started my flexible ureteroscopic surgery 15 years ago. At that time, I had no other option, only of 3 or 9 o'clock working channel. And when I just recognized the presence of 6 o'clock working channel, at that time, it is very new. I feel it's very new. But regarding the car's steering wheel, while driving, it's actually regarding the McFarlane F1. So they developed this based on Formula One technology and designed this the 3-seater vehicle with centrally positioned driver's seat, and it was not something new. So this company tried to explain with this centrally positioned driver's seat about a stable balance and wider field of vision and optimal sitting experience. So it is the same as the location of the working channel regarding the endoscopic view. So with the 3 and 9 o'clock working channel, actually the red area may represent that space of blind spots for endoscopic view. But with the 6 o'clock working channel, as we could get balanced view for both side kidneys, even in anterior posterior calluses. So now I feel why do we have to twist our wrists even more because of the blind spots during endoscopic surgery. So regarding the lower pole access for the lower pole stones with the laser fiber and basketing, actually this the 6 o'clock means inside the endoscopic view means the lowest part of the kidney with dependent area. So when you break some stones when you break the stones into the pieces, normally these fragments tend to gather in this lowest part, dependent areas. So actually just 6 o'clock working channel enable us to approach the lower pole stones with better accessibility. So I'm not such a person who trusts blindly the company's promotional materials. So I did the suction workshop because I wanted to find the best irrigation and suction settings in my place with my international fellows. Normally, just I have 10 to 15 international fellows from Asian countries and Middle East countries. So at that time, I could find when we try to access lower pole stones, when using a suction ureteral access, the deflection part of the scope can be critical regarding the scope damage, especially the surface area of the scope. So in some cases, with my international fellows, actually 2 disposable ureteroscopic devices were required to remove a single stone in the lower pole callus, especially when it is very big. So this view is, So now, as you can see, the most lowest part of the endoscopic view means the dependent position of this is applicable to both of the kidneys. And this is for basketing. So after it breaks the big stones into pieces, one-shot basketing can be very easy with 6 o'clock working channel. Okay. So, after I recognized the presence of 6 o'clock working channel, I already told you, this is not a new concept. Because all the endoscopes or endoscopes, cystoscopes have the working channel at 6 o'clock. So this aligned view of 6 o'clock working channel with mini nephroscope and cystoscope for just any procedure of RIRS, a PCNL, or the endoscopic combined intrarenal surgery, actually we could get intuitive visual view for both RIRS and PCNL with the 6 o'clock working channel. And just my international fellows feel very comfortable with this, the location of the working channel. So moving on, I want to just introduce some small accessory. Actually, just we are naming this in scope instrument control named port C. The C, it means Cho, actually, just I am Dr. Cho. So this small accessory, the port seal has two channels with locking mechanisms. So we can fixate the location of the laser fiber or basket without preventing any irrigation leakage. Even it is high pressure irrigation to our surgeons or our assistant during our RIRS procedure. And with this lever, after we fixate the location of the laser fiber just in front of the scope, we can advance the laser fiber by 6 millimeter. Advance. So if just, I thought that if this port seal enables us to position the laser and basket instrument precisely without additional locking and unlocking repetitive adjustments or the one-hand operation of laser and basket instruments while maintaining grip on the scope, I think this device can reduce the operative time by reducing repetitive unnecessary manual handling of laser and basket. And according to my previous investigation, actually, I just analyzed the 7 different types of laser fiber degradation during my RIRS procedure previously, but I don't want to tell you about 7 different types of laser damage. But according to my previous investigation, actually, the average laser degradation depth or length per RIRS session was 5 millimeter on average. And we calculate the number of adjustments to the laser fiber length per RIRS session was 5 to 17 times, and we had to spend for these advancements of 5 to 10 minutes per each RIRS procedure. So at that time, just we had to unlock the mechanism and lock mechanism again, and sometimes we have to change the fiber into basket or vice versa. So. And actually, we need to spend longer time if they are beginners with such as like our international fellows. So, at the time, actually, with this device, I anticipate the reduction of the operative time by just handling this unnecessary manipulation. And this was extremely helpful in some situations requiring more frequent laser fiber adjustment, like diverticular spaces, diverticular stones, and cases some stone is located deeply with acute infundibular pelvic angle or some anatomical abnormality because of the big parapelvic cyst. So at that time, so we need to adjust the laser fiber location so frequently, so it'll be very helpful. So with this 6 o'clock working channel flexible URS, port C, and suction ureteral access, I think that we can just increase the surgical outcome and surgical stone fragmentation efficiency and retrieval efficiency to a maximum value. So I think this in-scope instrument control for sheath suction can be the very just game changer to increase our stone fragmentation efficiency. So with this experience with the single-use flexible ureteroscope, I think this is I'm not sure. I wonder you will think this would be a big change, but I think this is one of the game changers for flexible ureteroscopic surgery with optimized visual quality, excellent durability, especially for primary deflection mechanism, and cost effectiveness with a single scope to manage the bilateral size renal stones, because only one scope can be necessary with balanced point, and ergonomic point of view with less hand rotation and less fatigue, and intuitive position of the 6 o'clock working channel with other types of endoscope. And ease of basketing can be achieved because of this location of the working channel in a dependent area of the lowest part of the kidneys. Thank you for your attention, and just thankfully last year just our hospital and department actually ranked the 4th in, according to the World Best Hospital 2025 in the Newsweek. But I'm not sure, just it is credible. But anyway, thankfully, it's just, we are doing my best, and I am finding, I'm just a stone surgeon to find the best treatment for my patients in collaboration with industry. So maybe just thank you for this opportunity to introduce some value about this. Thank you.